The taking of a centric record is in another portion of our tapes, but I think right now we will do a centric record for you very quickly.
We have to mount.
Yeah, we're going to mount, so we should take a centric record. If we have a set of casts like we have on Bruce, we can find out if the bite tray is too long, and it is a little long. We don't need to go farther back than just the second molars. I'll cut about 1/4 of an inch off of the tray like this. If it is too far back, it may touch the soft tissue in the retromolar area, and we don't want to do that. Okay, I think that'll handle it. This seems to be smooth enough. If it wasn't, I could polish it with a rubber wheel. Now, we have a midline mark right here. We put it right here at Bruce's midline. I put my fingers right over the bicuspids like this. I think if you back up just a little bit, you can see my fingers right here at the serrated areas. By doing that, I'm centering it in the lateral direction. Now, Bruce, I want you to squeeze your teeth together hard and crush it as hard as you can. Okay? Open. We take it out, and we can see the tooth marks and how he has crushed this and gotten his teeth together as close as possible. The next step then is to dry off the saliva. And then if you focus on what Olivia is doing over there on the table, she's painting the tray with Emperor Gum adhesive. There are other adhesives that you could use, but we find that the Emperor Gum adhesive is the best. And she's painting it only in the perforated areas, on the upper and lower side, both sides. Just a thin layer of that adhesive will work fine.
Why Emperor Gum? Is this
Any of them will work. Any adhesive. Rubber-based adhesive will work. In the old days, we used to use cavity varnish, but it's expensive and it's too thin. We just like the Emperor Gum adhesive better, but it's not the only thing you could use. Any adhesive will work. Olivia is now going to mix some co-nogenol. Once again, co-nogenol isn't the only paste for taking bite registrations. You could use Cur. But Cur has eugenol in it, and Co doesn't, and I like the Co a little better because, for one thing, it doesn't burn the patient. Secondly, it sets very hard. It's easier for me to trim down afterward. And thirdly, it doesn't cost as much. So there are quite a few factors why I like the Co. It doesn't dry out either if it sits around. And we're putting just about 1 millimeter or 2 thick over on the superior surface. Don't put any on the mandibular part, just the superior part. Just in the perforated areas. Now tap your teeth together. Tap, tap, tap. There. Now open slightly. The tapping will reposition it in its original position, and then you have them open their mouth slightly so that they don't flex it or intrude teeth or do something like that, or flex the jaw. The dental assistants will be doing this day after day, year after year. Okay, now we're ready to remove this, and I want to give you a few clues on removing it. Don't just grab it and pull down on it, but take it like this up front and take your fingers and just kind of shake it a little, especially around the anterior tooth areas, like that. And keep your index fingers on the lower side, on the inferior side, and your thumb on the upper so that you won't go way down with it, so you'll feel it when it breaks. And brace your hand against the patient's face. And if you just do that and shake it a little bit when you come down, you will not flex the bite tray. But if you just grab it with your fingernail and pull down on it, you're going to flex it almost every time, and you're going to put a permanent distortion in it. All right, now we take it and trim it back, and until we have just the cusp tips remaining. So we'll do this right in front of you here. Ordinarily, we'd let that set or put it in cold water a little bit. And in the cold water, it hardens it very quickly. But I think we can manage here. Looks pretty good. At this stage, it's just a little bit soft, but if you put it in cold water for just a few minutes, like 2 or 3 minutes, it'll harden it very hard. Be sure there are no loose pieces there. And after you've done this, the best thing to do is to take a brush and go under the running water. If you give me a toothbrush, I'll just go through the motions here, 4 of them. But under running water, you take the toothbrush and you just scrub it like this and get rid of any of the loose particles. That's important. And the running water will wash them away. Besides that, the running water, if you do that before you trim it back and then do it again afterwards, the running water will harden it very fast. Cold water will make it set quicker. All right, now we want to make sure that we have not distorted it. I put it up there, I push on the back of it, it's seated, push on this side, I see there's no rocking, push up in the front, it's totally stable. I did not warp it when I took it out. But the reason I didn't was because I had my fingers both on the upper and lower side, and I just shook my hand a little bit like that until I felt it just break loose. That did not permanently distort it. Now be sure the lower side is dry when you do this stage. So we'll check it with the air, get all moisture off of it. And we'll come in front of the camera, in front of the patient to do this. And what we have to have now is, I'll just move it out here just a little bit like this. Be sure that, because we're going to get this smoking hot, and we're going to heat about 3 centimeters. The mistake that a lot of people make is not heating enough of it and not getting it hot enough. It has to be smoking hot. And then, notice where I put it. You can take it away now, take the flame away. And I put a large glob. You got all kinds of working time. There's no big rush on this at all. You got a mile of time here, a lot of time, hour here. Just dip it down in the warm water. You just can relax, coast here, and that's going to stay soft for a long time. So with the patient now, like this, we hold it against the upper teeth, make sure it's seated. I put my index finger and my thumb over the serrated areas by the bicuspids like this, and my hand is right over the nose. Now be sure that you don't smother them. Be sure you leave a little room for them to breathe. Now I hold the lower lip back. Don't bite. That is important. Bruce, don't bite. Relax. And I hold, let's show what I'm doing with my thumb. I'm hinging him up and down, and I'm saying very, very slowly, come slowly, open please. Now, when he touched the compound, then I opened him, and here you can see an index right here of his teeth in their retruded position. We dip it quickly into the ice water. So you have both the hot water and the ice water, and the ice water will freeze it almost immediately, and now we can come back and try it in the mouth. I need a little gauze here. By the way, we're using that wonderful J&J baby oil for our fingers, and if you're still using that, what is orange solvent, don't use it. It burns the patient too much. Anyway, now can come back, and Olivia has done this, and she will have tested the patient now, and she will check the patient to see whether she has a patient retruded. Now listen, open slightly, slowly close. Tap, tap, tap. Now he's coming along pretty good, but he may be hitting in the back, so bite down please, just hold. And he is. That's why he was so careful not to close very hard. Open, bite down. This is a good learning process. Open please, bite down. You see, he's holding my paper, so he's hitting on the right side. You can't have that. I need to increase the vertical, or I have something in the way. Now let's look and see what I might have in the way back here. And you see there's some ZOE that has gotten down on that lower side, and it's touching. So I want to be sure and get that off, and I should have removed that before I took my registration. So I'll scrape it off now. Get it out of the way. Can we blow that off now? Might have a little more there. Yeah, okay. Right. Okay. Now we can go back and try it in the mouth. Open, please. Now relax. Tap, tap. Tap, tap, tap. And the jaws will become very loose then because the brain is beginning to trust this little compound jig out there, and it knows that there won't be any posterior contacts. Bite down, please. And here you see it's free. Open, bite down, open, bite down. Everything is free in the back of the mouth. Now, you don't want to open the bite more than you have to. I would say allow no more than 1 millimeter of space between your posterior teeth. No more than that. Now, if the patient was to hold on this little compound stop out here, the condyles will be lifted upward and forward because this becomes the rotational point out here, or the fulcrum right here. And the muscles are all lifting the entire condyle complex upward and forward against the disc. Okay, open please. So I can't get the patient any farther back. I don't get any skidding. It's absolutely hard. We'll trust that one then. And if these indentations are too deep, we cut them back with a knife. These are not. They're only about 1 millimeter deep, so we'll leave it. But if they're any deeper than that, then I would shave it back with a Bard Parker knife. With the tray dry, we'll put the lower half on now. And on the lower half, you have to put a little more paste than you do on the upper because you've opened the vertical dimension a little bit. You've increased it. And we want to get all of the teeth, or as many teeth as we can, on this lower half because we want to prove the accuracy of our mandibular casts. Now, Bruce has a fairly wide arch, and what I could have done is to have flattened this bite tray out a little more and made it a little wider, but it's working. It's okay. And here you see the paste for the lower half. You may have to put it 2 or 3 millimeters thick here. I usually don't put it over the compound because I like to use the compound for positioning. Now bite together, close. Now you see the patient knows right where to go. He just retrudes his own mandible, and I stand behind the patients like this, and the patients should not clench. Just close your mouth normally, but don't clench, because if they clench, they can flex the mandible, compress the disc, intrude the lower teeth, flex the tray, and you can get a lot of inaccuracies. And you don't have to worry about a power centric, believe me. There are powerful muscles closing this jaw, and I put my fingers right along the lower border so I can feel the masseter muscles. And if I feel a patient clenching while I'm doing that, I tell them, just relax, don't clench. They know what clenching is. So if you say clench or don't clench, they understand that language. But centric relation to us is the lower teeth in their most retruded position, and the condyles are in their upper foremost position. It's a three-dimensional thing. You could have the condyle, you could have the lower incisors rearmost, but the condyles aren't uppermost with some methods. Open, please. Now, we hold it against the upper teeth when he opens his mouth. That's what I was doing. I was holding them tight against his upper teeth while he opened his mouth, and here you can see the lower half. Now, we'll put it in the cold water, and we'll just leave it there until we're ready to use it. I think now we're ready to switch to the laboratory phase. Bruce and Olivia, my assistant, would put the cotton roll between Bruce's teeth while we were taking the centric record. This cotton roll acts as somewhat of a deprogrammer for the patient. It allows the patient not to bring their teeth back into their acquired centric position. And that way we can keep the muscles relaxed, and they won't set up avoidance patterns so quickly. As I said, there are other methods of doing that. You can put people on leaf gauges and leave them, or you can put them on occlusal splints, which are even better. And the centric relation record that we took today is not necessarily his final stable condyle position. That would be determined with an occlusal splint in our office. But this is what we call a database record. This is day one. This is the day that Bruce first comes to our office. Well, it might be his second appointment in our office. But this is the day we are collecting our database. And that is usually, in many cases, most cases, an unstable condyle position. That doesn't mean that the patient has TMJ dysfunction necessarily, or pain, or clicks, or anything like that. But the centric relation position is not usually their stable position. So I'm not sure whether we should put patients on leaf gauges or occlusal splints until we've collected our database. Because we like to see where they were the day one when they came to us and where they go when we're treating. So the cotton roll is just a mild way of helping the people at that moment to keep their teeth apart while we're taking our records. But that does not necessarily mean that I trust that centric there as your final condyle position. I probably do not trust it. As a matter of fact, I do not trust it until I've proven it. So when we start with our patients in doing diagnosing, we start with them as they are, disc or no disc, fluids imbalance and all sorts of muscular problems, but I have to have a database where I don't know which direction I'm going during my treatments. And that all this was today is a database. That means for our database records, what we want are your lower teeth rearmost and your condyles uppermost and foremost. Okay, from that position, we will now mount you, and then as we treat you, we will know where we were to start with and where you are when you are stable. And we have ways of determining then when he is stable in his occlusion. We do that with occlusal splints, etc. Okay, or that condyle position indicator system, which helps us to know when he's stable. All right, now somebody had a question.
So you're saying your centric relation is not the same as the terminal hinge axis?
Yes, during the recording I made the remark that the terminal hinge position is not necessarily coincidental with centric relation. And let me explain that. Ordinarily, centric relation position, as far as we describe it, is the uppermost, foremost position of the condyle in that direction. And the lower teeth down here are rearmost. That is, they're as far back as they can go in this direction. If you were to look at the rhombus, Basalt's rhombus like that, you would see that CO and CR are synonymous right here. This is CO and CR. It would be the apex. In other words, in the horizontal plane, they would be right there. That the tip CO would be synonymous with CR. And now the condyles are uppermost and foremost. That is centric relation. All right? Now, I said that sometimes when you're pushing on the mandible here and you're locating the terminal hinge position, it is conceivable that you could push the condyle slightly back a little bit. It's conceivable. It is not seated perfectly against the disc. It could be slightly back because of the pressure you're putting on here. All right? So you locate the axis, and just remember this represents the mandible here, the center of rotation. But when that condyle is seated upward and foremost, this position might move up here a millimeter or so when it seats itself right here. So locating the hinge axis by putting pressure here might push the condyle back a little bit. If you use the bilateral manipulation of Dawson when you're locating the axis, then you will have your condyle up here, but I was using chin point. I've done it both ways. I've used a Dawson bilateral manipulation for locating the hinge axis. I've also used this here. And I would say that if you bilaterally manipulated with the Dawson technique, you'd have the condyle, the axis would be coincidental with your CR position. Well, you say, well, isn't that a discrepancy? Well, the hinge axis is not determining my centric relation totally. The hinge axis is close to this position, and I hope it wouldn't be more than a millimeter away, but probably if I didn't locate the axis closer than a millimeter anyway. If I got within 1 millimeter, I'm getting pretty good. Yeah.
So your first day database record CR is really a CO then? Until you are
right, until we make it CR.
Right.
Yes, our database record here is on an unstable joint. Even this, if you even used a Dawson technique for bilateral manipulation, you still are going to have an upward forward movement of that. On most of your patients, it's going to go upward and forward anyway. you're dealing with an unstable joint to begin with. How do I know that? Just experience. Now when I say you are, I'm saying 99% of the time you are. There isn't, in my experience, one person in 100 that has a stable centric unless I've proven it. And it usually takes a little treatment. There could be 90%. When I say 99%, let's say 9 out of 10 times, easily, that the centric relation position changes on my patient unless I stabilize them first with an occlusal splint, which is properly adjusted. So, even if you did use a bilateral manipulation and you located the hinge axis and it was coincidental with the CO and CR as of this date, 20/87, that's the CR this afternoon at 3 o'clock. What's it going to be tomorrow on an unstable joint? This disc may thin out in here, which it often does, and the condyle seats in there in a thinner position. This axis is moved upward when the condyle moves up. So we are only saying that this is our database record now. If I wanted to really be sure, I would relocate the hinge axis after occlusal splint therapy on a dysfunctional patient and do the whole tracing all over again once you've gotten the patient stable. So this is a database. And then after occlusal splint therapy, you should go back and retrace the patient. So if you don't want to mark the axis permanently the first time around, then wait until you've had occlusal splint therapy and then mark the axis, and you'll have a better chance of having this CO-CR relationship at the same point here with your hinge axis. All right, any other questions? Let's go ahead and do our mounting now. All right, now Olivia has beefed up these models and she's taken off the paper dam, and I'm now going to the articulator and place the model on the articulator like this, tighten it down like this, and it's fitting. We have what we call a mandibular mounting stand. Before this we had a mounting block, but we've come up with a little more convenient device. And the mounting stand, this one, is just for mounting the lower cast. So we take off the dynalinks like this, turn the articulator like this, open it, and drop it in here, and then put the dynalink pins in those little holes that go into the analogs, and that will support it back there. Now, one nice thing about this is that we can drop this down and level our models. And remember, sometimes when you mount, the models are this way or the plaster runs off. We'll show you how you can avoid that. We have a mandibular cast. Okay, now I'm going to put the retention lug on the lower frame. I'm also going to put my paper dam on, which we call a plaster dam. Stretch it tight. Pull it back on itself like this and paste it down. There's adhesive there. The next thing, of course, is to hit it just a little bit like this. Now we want to also open the incisal pin about as much as we think we have increased the vertical here. And I usually find that about 2 to 3 degrees. I'll go 2.5 degrees since this is a curved incisal pin. I then want to put 2 little rubber bands on like this to help hold the mandibular cast on. And let's see how the centric record fits. And we know we have an accurate maxillary cast. Seems to fit good. Let's look at the mandibular cast and see how it fits. Looks good. Now if it doesn't fit, we know that it's the model that's wrong. It's not the centric record, because we checked the centric record in the mouth and it fit perfectly. So I then close this over to see if I have to trim the cast, and yes, we're going to have to do a little bit of trimming. It almost touches, and I think we could use it that way. We probably won't have to trim it, but we could cut a little bit off. I like a little bit of space in there, like about 5 millimeters. But remember, the paper dam is taking up a little of the space. So we won't trim this one. It looks good. We'll crisscross our rubber bands like this. And someone asks, well, can you use sticky wax? Have you ever tried to get wax to stick to wet models? Yeah. These are wet models, so we're going to do it this way. Now, one thing you want, be sure your latch is on back here. This is important. See the latch? Be sure that's snapped on. because you want to keep this, the posterior of your articulator, keep those condylar elements seated in centric relation, and then you can assure that only when the latch is on. Then you can open it back like this. Let's say that your model wasn't level here at this surface. You can raise it like this. Now I'm not raising the incisal pin, I'm raising the support leg like this to make this area flat where I can place my soft stone. Also, what I'm doing by raising that up there, I'm giving myself a little more room. Alright? We will then put the soft plaster in around that retention lug, and then fill the little paper cup up right level with the top like that. You then put a little bit here. In this case we're not going to need much, so just spread it out like that, close it over like this, and wipe off any excess that happens to ooze through like that. And this one is really close. We could have ground the model. It could easily have been ground a lot more. Now while that's setting, I don't like to leave it like this. I like to put my fingers on it and hold it down like this. Because one day last year we had 100 earthquakes here in one day. In a 24-hour period we had 100 earthquakes, registering 3-point or more on the Richter scale, according to the experts. And I just know that we're sitting right on the San Andreas Fault, and if it isn't an earthquake, it's a big truck going down the street, or that jackhammer that you heard outside here today, or an airplane crashing the sound barrier, or the air conditioner goes on, or somebody bumps the table. There are a lot of things that can destroy it. This is one of the most important steps in mounting casts. Right here. Taking the centric record is one important step, but mounting it is another. So I'm holding straight down over the bicuspids, and my hand is resting on the articulator frame, and I'll hold it this way until it reaches the initial heat stage. Okay. All right, we're ready to take the articulator off the mounting stand, so I'll cut these elastics like this. The next step then is to remove the Dynalink pins like this, pull them out like that, and we can take it completely out, and we have our models mounted. And now we will beef up the lower model here and then run the articulator through the movements. All right, now to get the final guide system into the articulator, we mounted here with the number 1 millimeter analogs, but the patient had 2 millimeter analogs. So with this system, the analogs are interchangeable. You don't lose centric relation. You can remove these analogs with these 2 screws. These 2 thumb screws are loosened. Take off the number 1s, put the number 2s on like this, and we can then set the angular setting according to what we had over there on the patient's chart. And we had, the right was 8, so I rotate it down to 8 right here, reading right along the side of the articulator, and you can see it right here. And I'm setting it at 8. And on the other side, it was 6 on the left side, so I will rotate the left side down to 6 right here. And then lock the thumb screw, and then immediately lock this set screw back here to hold that position. Put the articulator back together again. Put the Dynalinks in. Like this. And on this side, snap that one in. Like that. Now remember that we had a space between the teeth when we took the centric record out, and we now have to raise the incisal pin like this, and then let the teeth come together. And they will still be in centric relation because we mounted on the hinge axis.